Hello everyone, in this video we're going to be discussing high altitude pulmonary edema. At a high altitudes, we're going to have lower oxygen levels. As a result, we're going to have decreased arterial oxygen. During hypoxemic states, our pulmonary vasculature is going to constrict, giving us pulmonary hypertension. In some people, this vasoconstriction is not going to be even. As a result, some areas are going to be overperfused. This in return is going to cause alveolar capillary membrane damage. So here, for example, we're going to experience damage, which is then going to lead to fluid leaving our capillaries, which is then going to cause edema. So this is the hallmark of high altitude pulmonary edema. Because of the overperfusion causing alveolar capillary membrane damage, we're going to have leakage of fluid into the interstitial space, giving us pulmonary edema. Now, on imaging, what we're going to observe is going to be these patchy infiltrates that is going to be diffused throughout the lungs bilaterally. And the reason for this is because the damage is going to occur all over the lungs, so we're going to see these patchy infiltrates diffuse throughout the lungs. Now, some of the clinical features of high altitude pulmonary edema is going to be dyspnea, which is going to be progressive over 1 to 2 days. Some patients also experience cough along with blood. Accompanying symptoms include acute mountain sickness like headache and nausea. Physical examination is going to reveal bilateral lung crackles. This makes sense because we have fluid within our lungs. And the hypoxemia is going to improve with supplemental oxygen. And this is important to know because it is going to differentiate high altitude pulmonary edema from other causes of pulmonary edema. And it is important to know that high altitude pulmonary edema is very serious and can be fatal. As a result, we need to lower patients into lower altitudes as soon as we can because symptoms usually resolve when they are lowered to lower altitudes. Here in this image, what we see is as altitude is increased, we're going to have lower partial pressures of oxygen. So patients are going to be at a higher risk at higher altitudes of developing high altitude pulmonary edema. So let's do a question. A 23-year-old man comes to the urgent care clinic due to dyspnea. The patient is on a ski vacation at an altitude of 9,600 feet. On arrival 4 days ago, he experienced mild headache and nausea that resolved spontaneously, but since yesterday, he has had worsening dyspnea and cough. The patient now feels short of breath even with minimal exertion. Respirations are 22, oxygen saturation is 86%, which rapidly improves to 95% with supplemental oxygen. Physical exam shows bilateral inspiratory crackles. Chest X-ray reveals patchy alveolar infiltrates. Which of the following is most likely cause of this patient's current condition? As we said earlier, the hallmark of high altitude pulmonary edema is the alveolar capillary membrane damage. So our answer is going to be answer choice A. Answer choice B is increased total red blood cell mass. This is not going to be the answer, although it can happen at high altitudes. It won't lead to pulmonary edema as we see with our patients. So the chest x-ray revealed patch alveolar infiltrates, which is going to be the hallmark finding on chest x-ray with high altitude pulmonary edema.